All right, guys, welcome back. Today I'm using the same sketchbook sketch as yesterday, except now I've added a number of images. So I want us to be able to go from the textbook image, or not even necessarily the ultrasound textbook image, just the anatomy drawings, to what you see on ultrasound. So some of the images I grabbed are really good. Some of them are purposely not so good because we need to see those. We need to work on the not so good imaging. So all right, well let's just jump to it here. Share screen. This screen. Okay. And so here are my images. So as you guys remember from yesterday's video, we kind of went over all of this mess in here, and it is a mess of vessels. So we're going to try to work this out, though. Oop. Zoom in on my, never mind. Let's see. I got to move a few things around here, guys. Sorry. Okay. All right, I think you guys are familiar. Let's see, I want to draw with, let's do light blue. That's pretty. Let's see. Well, this person was correct. Celiac trunk, yes. Aorta down here, of course. Celiac trunk coming up here, and you can almost see there's a couple of vessels just waiting to pop off in the trunk right there. You know, at first I was thinking, and this might very well be the left gastric artery. Oh dear. Okay, good. I was able to. Left gastric artery. I'm going to put a question mark right on this one because it's certainly possible. I mean, there's no reason why the left gastric artery wouldn't come off the bottom of the vessel here. Normally we see it coming off like over here. But the other thing this could be is actually this could be the crust of the diaphragm coming all the way up and kind of having the appearance of coming of a vessel, where it's actually the crust of the diaphragm. But I'm leaning toward LGA, left gastric artery there. And of course, we know that this is the SMA, and this is the normal angle takeoff of the SMA. If it does something funny, you just pay attention. It doesn't mean, you know, we do have one person, a couple people actually, but one person in particular in our group whose SMA does that. Now we've determined that there's no problems in our classroom, but it could be. It could be an indication that there's something large underneath the SMA forcing it up like that. So just pay attention when that happens. Of course, we know what this is right here, right? What is that, guys? Say it to yourselves, say it out loud. The left renal vein as it crosses in between the two here. What else can we say about here? We have a stomach here. And yeah, you know, a little hard for even for me to say, but yeah, this is that's some pancreas, some pancreatic tissue with looks like probably splenic vein here. It's just kind of weird to have a. It's like a very thin pancreas. So that's the only thing that's keeping me from saying yes, absolutely, for sure. That's a pretty typical look. You know, a lot of times we have a harder time because different people have different configurations. Sometimes the stomach Sometimes the stomach is up here, and the liver only goes that far, and it's causing shadowing. So different people, different configurations of the body will provide very different results on our ability to see and hear, to see in that area. We do have one person in our class who has extremely small left lobe of the liver. That means that they will always be a difficult scan in the mid-epigastrium. Now here's, oh, this is great. Obviously another sagittal image. This truly is, that's definitely the crus of the diaphragm there. You can see that it goes all the way up, just touches the celiac trunk. Doesn't mean it's a problem, but always pay attention to that when the patient, not when they inhale, but when they exhale deeply, sometimes this crust can impinge on this artery. We had a student in the group prior to you guys that had that syndrome, and that's called MALS, by the way, on median arcuate, MALS, median arcuate ligament syndrome. And so they call this the median arcuate ligament, kind of comes across right there. And every time she would breathe out, exhale, her artery went from a regular, oh, this is a fairly quick artery normally, so let's say like 140 centimeters per second, 120 centimeters per second. And every time she would breathe out, it would go up to 300, 400 centimeters per second because she was creating a stenosis every time she would breathe out. Now this truly then is the left gastric artery here, LGA for sure. And after looking at this, I'm going to put a double question mark here, because look at this. That's exactly what you would expect of the crust of the diaphragm. And perhaps this little booger right there is the LGA. I just don't know. Don't know for sure. But that's okay. It's only a single image. If I were scanning the patient, I would know. Okay, so, you know, superior mesenteric artery. Here's that vein again, left renal vein. Wow, this person's stomach is like not even existent. Is this it? All the way down here? That's awesome. Empty and out of the way, which makes this pancreas here. This splenic vein, yeah. This splenic vein is, this person's built a little bit differently. Splenic vein is normally posterior to the pancreas. Well, it is posterior, but it's also very superior. So this person's built a little funny. And that's not an insult. I hope no one feels insulted when I tell them they're built funny on the inside. Of course, we do have one patient who's ugly, or one student who's ugly on the inside. You know who you are. Let's see a transverse image in this area. Let's see what we're, okay, let's pick out the obvious first. So we have left lobe of liver. We're just getting a bit of that. And obviously this is the IVC because it's labeled IVC. And it's pointing out there because actually there's a vessel. Of course, veins always go back to the center and back to the heart. So obviously the blood better be flowing that direction. And of course, what vessel is this? Left renal vein, right? Okay, aorta is pretty obvious there. And of course, in transverse, what's this circle? Almost always surrounded by a pretty obvious connective tissue, fatty tissue. That is the superior mesenteric artery. And there's that renal vein as we see it in long. As we see it in long, right there. This is what it looks like in transverse. Right there. Okay, looks like we do have some pancreatic tissue here, but what I'm not seeing, and it's just right up. Wait a minute, why am I not seeing it? Let's think about why I'm not seeing the superior mesenteric vein. It must already has turned away. Okay, yeah. So like we said before, different strokes, different folks, different anatomy. We're not seeing the SMV probably because we're just a little bit too high on this particular person. We come down 1 centimeter and we probably see the confluence. Now I've seen, by the way, this confluence, and let's just pretend a confluence and then also a vein going down. I've seen this confluence referred to as the SMV, as the confluence, as the portal, as a splenic vein. All of them are true. All of them are true because it really is. It's the splenic. This is the splenic vein. I kind of imagined a splenic vein coming up over here. It's also the SMV, which is, you know, coming in from your point of view as the viewer of this video. It's coming straight in to there. It's also the beginning of the portal vein. So all of those things are correct. I think I'm also seeing a little bit of renal artery here. So the full course of that renal artery always comes up a little high, then down low, and then over to the, so that would be right renal artery, looks like we're seeing there. Hard to tell just from that one little picture. Okay, that's about it for that image. Now here we have one. This is a little more expected and as far as anatomy goes. So this, let's call this one a little more normal. Here's our confluence or SMV. Let's see, today I'll call it an SMV. Tomorrow I'll call it a confluence. Got to use all the terms because that's what other people are doing, so we got to be careful of that. All right, here's our SMA, our IVC, once again pointing across because it is connected to the left renal. Someone made a mistake there. Left renal vein. By the way, the left renal artery, if we were to see it, usually comes off right about here. It goes down like that. The right renal always comes up a little high. I don't know why. Maybe he'll die. Anyway, I don't know why it always comes up a little high like that on this side and lower on that side. You'd think it would start low because it has to go under the IVC anyway. Mysteries of life. What else can we see in this? Scratched out. What is this? Is that the is this the pancreatic duct? Right in the middle of the pancreas? Like this is all pancreas, right? Pancreatic duct. Well, I'll tell you what, if it is the duct, you got to measure it. That is too big. But here's the good news for this patient. It's not the duct. What is it? The wall, the stomach. So the bulk of the stomach is over here as it's reaching out over here to the duodenum. Duodenum's over here. Basically, the end of the stomach is right there. That's called the pylorus, by the way. That muscle. Anywho, get rid of that because it's not what it looks like on the adult. So yeah, so that's a sneaky People get confused by this all the time and call that the pancreatic duct. It's happened to me, so no big deal. Oh, let's measure the head here, by the way. We've had some questions on measurement of the head, and I don't blame you because we haven't really covered it enough. So, okay, well, I'm definitely down here. I'm very comfortable with where the head ends. I think it ends right about there. So there's my measurement. And there's no reason I couldn't say right here. I've actually make it a little bit higher. But I just want to make sure in live imaging that that is the head measurement, or one of those two would be the head measurement. This is the uncinate process is there. If you're going to call it a neck, that would be the neck, body, and tail. See, I guess we can count that as tail right there. And that's how I would measure that. But I'm also, guys, I'm only going to have you measure the head. If you need to measure body and tail when you go out there in the field, that's fine. Okay. I don't think there's anything really new. Oh yeah, that's right. That's right. So I'm going over this picture and I'm like, yes, 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 yes. Whoa, whoa, whoa. Gallbladder. IVC. Now that was a head scratcher. I have to say, I sat there for a little bit saying, well, could the gallbladder be? Yeah, the gallbladder could be there. So that, yeah, that could be gallbladder. And the IVC is kind of squeezed up next to it. And so I guess I'm not 100% on that, because when we go, that one really bothered me. I was like, you know what, I'm not going to include this picture because I don't know what to make of that. Normal. And then look at this. Same picture, just in much better. It's not the same exact picture. I thought it was the same exact picture, just better quality. Interesting. So yeah, but anyway, here, this is a little more expected. IVC, aorta, and then renal vein. Here's the question though. I mean, this one might be wrong. The IVC is normally, it can be this large. It absolutely can be. But the pressure in the body usually forces it shut so that it's a little more shaped like that. So this very well could be IVC. Am I seeing a gallbladder wall? Not really, but then again, you know, what's the difference between a gallbladder wall and an IVC wall? Not that much difference. Certainly it does appear that this is a real opening. This could be a fake out. It could just be hypoechoic, and this really could be the IVC. But then again, no, it can't. Yep. This one is correct. And let me tell you why. The IVC does not float unless there's a tumor underneath, which I'm not seeing here. I'm just seeing tissue. The IVC does not float up high. The IVC lays down on the back of the body. It only floats up higher when it gets really close to the heart and it has to come up to meet the heart. And it's not quite there yet. So yeah, this is the IVC for sure. Why the renal vein is fat right here? Don't know. It's a little strange. That's a little strange. And that's why over here they called this the IVC. This is so weird. This has got to be the same person. God, this is so strange, but definitely That's why they called this the IVC, and that's the gallbladder. Although this one's not floating as much. All right, well, I'm the instructor. I'm supposed to be giving you absolutes. Or I could be teaching a lesson that we don't always have all the answers. That is crazy. But other things going on, this person has a rather large common bile duct. Pretty large. Can't miss that common bile duct. GDA, yeah, I suppose. Kind of a little bit of a funny shape on the head, but that's fine. Everyone's got. Well, so let's go. Measure the head straight up and down. That is not in. This is free fluid, and what we would do is write FF right on the screen. We can go ahead and write F. Actually, it's better to write F over here and then arrow like that, so you're not drawing on the picture itself. Doctors don't necessarily like that because you could be drawing over something important. But this fluid is not inside the stomach. It's not inside the duodenum. That is free fluid. There's no wall on this. It goes from fluid liver, fluid head of the pancreas. There is like nothing in between there. So that's concerning. That's absolutely unnatural. So something's going on with this person. Let's see, aorta, SMA, what they're all calling the splenic vein. Well, it is. It's splenic vein all the way up to about here, and then who knows? When you want to call it splenic vein, that's fine. Want to call it confluence, that's fine. Okay, let's move on. Dun, dun, dun. So here's the thing about the seagull sign. It's very variable. You could have the celiac axis do this, and then like that. You could have it do that, of course, because that's what that's doing. We have one person in this class who does not really have a celiac axis. They have one shared trunk, and so they have a seagull without a body, and the reason being is because it comes off of the SMA rather than off the celiac trunk. So that's kind of a cool variant. We had someone last semester or last class who had a N1 level. You would see the hepatic artery. So this is, of course, this is hepatic artery over here, and this is splenic artery over here. We had a student last class who had an hepatic artery attached directly to the aorta and a splenic artery attached directly to the aorta. So in long, my student had this configuration. This is SMA, and then she had, I can't remember which one was which, but basically hepatic artery, splenic artery. So she essentially had two celiac trunks, which is kind of cool. What else can we garner from this image? Well, from this picture, we only have the tail of the pancreas. It's a little unusual. Of course, left lobe of liver. By the way, guys, see this little achegenicity in the left lobe? Is that a hepatic vein? Hopefully you didn't say yes. It is a portal triad, just very small. It's obviously they get small as they go out to the edges of the liver. Portal triad, echogenic. And here, look at this. A large IVC, so a large round IVC. They're holding their breath. It's created higher pressure and internal pressure. The IVC increased in size, so that is not at all unexpected. I do not think that was a gallbladder on that last image. Lymph node, I think, probably. Okay, let's move to the next. We have another one. This one's a very similar. Just wondering if it was the same person. Because sometimes they are. They come from, there's like multiple pictures from the same article. But this one does the same thing. Aorta, celiac trunk comes up this way. IVC, once again, is enlarged. Left lobe liver. How do I identify that? I don't know what I'm looking at right there. Huh. No need to sit there and stare at it if we don't even know what we're looking at. Okay. Normal configuration. AA is aortic aneurysm, abdominal aorta. Normal configuration. So this is further down. This is more inferior in the body. We're not seeing any other mesenteric arteries. We're not seeing pancreas or anything. It's a little further down. SMA over here, SMV over here. That's a normal configuration. SMA more or less anterior to the aorta. And of course, if you find the SMA way over here, that is an issue. Could be that the intestines have either recently twisted or twisted in, or had abnormal twisting in utero. I think I'm good. I just grabbed this just because I looked at it and surprisingly everything was correct. So yeah, head, onsonate process, neck, body, tail, splenic vein. Where it's getting cut off. So if we could see the whole vein, it would come all the way up to here. They call it SMV. I'm not going to argue it. That's fine. SMV, SMA. Left renal. On this person, the left renal vein is plenty big, going through the space between the aorta and SMA. There's nothing unusual about that. It's just, or nothing wrong with it. It's just, there we go. Yeah, that's good. Oh, and of course, I just threw this one in here last minute. What is that? What is this? Distal aorta. I mean, it's not. This isn't the distal aorta, but we're at the level of distal aorta. What is that? What is that? Inferior mesenteric artery. Inferior mesenteric artery right there, guys. Just off to the left, patient's left. And I just grabbed this picture just to kind of help. I don't know. Sometimes these pictures are worse because they're such a mess. But we just saw that the SMA is to the patient's left of the SMV. Of course, I think we all know the configuration of the SMA going into the aorta pretty well. But here, let's follow this SMV up, right up until this point. And it also meets up with the splenic vein to come up at more or less a 45-degree angle. So main portal vein there. Right portal vein here. And remember I said the left has a pretty sharp turn. That's left portal vein there. By the way, yes, there is an inferior mesenteric vein that also comes up here. We rarely see this. This is a very rare thing to see, so we don't even really bother talking about that. Okay, I think everything else in that picture is a little difficult to look at. All right. Oh. So this one is labeled in such a way that I'm questioning it. I would have to really be there in order to see that this is correct. The reason being is they're calling this the right hepatic vein. And perhaps they're imaging from a window that I'm not accustomed to. And it might very well be. It might very well be that that truly is the right hepatic vein. But normally when I'm looking at it, the right hepatic vein is a little more over here. The middle hepatic vein is there. And then the left is more straight up and down. And there can be an extra branch that doesn't stop making this the left. So I question the accuracy of this one. This one, though, is pretty clear. And you see how there's a double, once again, there's a double branch over here on the left. But this is clearly left hepatic vein, middle, whoop, hepatic vein, and this is right hepatic vein. Oh, dang it, just go away from me. But anyway, let's look at, and I know I've repeated myself on this a couple of times, but it's worth repeating. On the screen, it's up, 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 you know, left, middle, and right, but they're coming down. The IVC here, heart here, but they're going up on the screen. And we draw this here, and it's going down, really, right? Down, down, and down. And that's because our transducer is well underneath the costal line, kind of the lower right epigastrium area, and we're looking up, and our image is upside down. So just keep that in mind. Really helps when you're looking for something and you stop and think about, okay, where is it actually in the body? That's why I keep pointing. This is where the gallbladder is, because I want you guys to be able to come at it from different directions, but always aim your transducer in the correct direction. A lot of times when we're looking for these hepatics, I see people who are even qualified technologists. The first thing they do is they sweep downward on the body. Well, that kind of makes sense when you look at the image. The image looks like it's down, and so your mind just says, oh, it's down. I just want you to remember the hepatics come from, basically, this is the heart. If that's the heart, you know the heart's not down in the belly, it's up in the chest. So that's where it is. Okay, this is the most idealized, we rarely get it this beautiful, but the most idealized normal hepatic venous flow, hepatic vein venous flow, or flow, anyway. I can't remember A, C, F, D's, all these different points. I don't bother with that. But it's a W, a W, a W. A little bit of reversal is fine. By the way, the farther away you are, like let's say on this person, if we we want the best Doppler angle. So if we do this right here, we might get this waveform. If we, on the other hand, Doppler right there, we would get that waveform, but far more diminished and perhaps not reversed, and perhaps it would be more, so it'd be far more diminished, not not nearly as phasic, multiphasic as that. Let's see. And however, if you are close to the IVC and you don't get anything like this, you just get constant wave without any kind of real variation, that's an indication of liver disease, because the liver is so swollen or hardened by fibrosis that it's not allowing that kind of a waveform. I think I grabbed this just to kind of show that, you know, a common trunk is not unheard of for the left and the middle. So that's just some things that can happen. Portal veins. Now this one's labeled main portal vein. Oh, yes. But like I keep beating into you guys, let's see. Here's the edge of the liver is, oops, kind of along here. That's the edge of the liver. I guarantee you that what's happening is this is main portal vein for sure. This is right portal vein. The left goes off in a funny angle. You can't see it. That's actually gallbladder here. And yeah, I guess that's IVC there. And this is a hepatic vein. And that's going to be going back to that IVC. Anyways, main portal vein, right portal vein. Look, it is always best to get your CBD measurements out here, because if you do it over here, it's not the common bile duct, and you're not really giving the doctor what they've asked for. So that's probably the biggest reason why I'm beating this into your head that this is the right portal vein over here, and that's the main portal vein there. What's happening is right about there, the left portal vein is taking a sharp turn. This is an impossible image. Well, it's not impossible because they got it, but this is very, very, very unusual. I've described this, guys, as a three-legged stool, and that you could only see two legs of the stool at once. Somehow, this technologist, or just because of the anatomy of this person, we're actually able to get the main portal vein, the right portal vein, and the left portal vein all in one picture. I have never achieved that picture, so congratulations to them. This picture is kind of cool. It looks like an angry Cartman, but this is left portal vein. This is right portal vein. And what we're not seeing, we can't see here, is that there's a main portal vein feeding into that and splitting off. This is IVC. Once again, this is left portal vein. This is my little man. Once again, we actually see this upside down. In reality, this is hanging upside down so you know, I imagine this is a head, you know, there's no head, but these are the arms. In reality, it's actually the other way around, but I don't even bother drawing it up that way. It just gets confusing. U stands for umbilical segment. It's not called the little, I literally had someone thought it was called the little man segment. No, it's umbilical segment. What we're not seeing in this picture, but sometimes we will, is the ligamentum teres. That, as you move downward, inferior, the ligamentum teres will attach to where the head is. And then what you are seeing is a little bit of echogenicity here. And you see that line right there? This is the, we call it the ligamentum venosum. It's actually the fissure that the ligamentum venosum is somewhere inside of it. What everyone calls the entire thing the ligamentum venosum. So that's fine. If everyone's doing it, you know, you jump in the lake too. But and so just to remind you, intrauterine blood when you were in utero came through this section right here into here, and then somehow dove. You can't see it in this direction. You can't see how it does it, but it comes from here through the ligamentum venosum into the IVC, into the heart. Okay. Main portal vein. So this person, by the way, they took it just out here. So that's really, yeah, that's main portal vein. They've got it. And so heartbeat is okay. We really don't see respiratory variation. That would be a longer term. So like if it went down lower down here and then came back up, that would be respiratory. But this person, perhaps they're holding their breath. So there's no respiratory variation if they're holding their breath. This person though, what's going on here? You remember when the portal vein is changing direction? On your screen up here, it's going to be red, blue, red, blue, red, blue. Down here, I'm going to call it like this. This would be red, of course, drawn in blue. Red, blue, red, blue, red, blue. What does this person have? Is it cirrhosis? Pre-sinusoidal, sinusoidal, post-sinusoidal? This person might actually get post-sinusoidal cirrhosis at one point, but this person does not have, well, this person's problem, primary problem with this image is not cirrhosis, it is heart failure. This person, the back pressure on the, what should be a low pressure right atrium is too high. It's so high that it's going all the way through. Now this person's hepatics will be a mess too, but it's going all the way back to the liver and back pressure going all the way through. So that's a bad thing. Now what's wrong with this image? Hepatopedal? No. Hepatofugal. Reversed flow seen in the spectral. Reversed flow seen up here as well. It's red is towards the transducer. We should be seeing red. We see red in the artery. See that? Hepatic artery is going in the correct direction. And it's hepatic artery is feeding this liver, but the liver is so fibrotic that the portal vein can't feed the liver as well. So instead, blood's coming in through the artery and then out through the portal vein. And of course the hepatic veins as well, but the portal vein is not able to move blood forward hepatopedally like it should. So that's this, well, of course, this is, we have the ascites up here. This is cirrhosis. Years of doing this, I still have trouble spelling cirrhosis. So with, and so this is portal cirrhosis and portal hypertension. Other signs of hypertension, the portal vein might be going in the right direction, but still having trouble going through. And so in the spleen, in front of the spleen, near the I've shown you this picture before because I've never been able to figure out, renal varices, but splenorenal varices. That's what it is. So let's see. The spleen is it's just very slightly enlarged, but definitely has varices. These are all veins out here that are way too big. That's evidence of portal hypertension. More evidence of portal hypertension. What is this? So if we got liver here, IVC here, I don't know where the heck the aorta is, but should be down there. Got all these varices here again, right? These varices, though, are outside the liver. These do appear to be venous. What these are, this is evidence anyway of esophageal. The lower esophagus probably has varices as well, and that is especially bad because those can bleed, and the patient will actually bleed out. The battery's running low. It would help if I plugged it in. Here we go. These are especially bad type of varices because the patient can bleed to death more easily than other types of varices. But they're all bad. And the reason these are esophageal, by the way, guys, is there is a, let's just draw a quick, let's just kind of pretend draw in our, let's see, there's a main portal vein here. What we don't usually see, and it's too small, is that there's a tiny little vein that goes into the main portal vein. The left, oftentimes called the left gastric vein, sometimes a coronary vein, I believe. It's another term for it, but that guy goes all the way up into the stomach, but also into the lower esophagus. And so the varices would continue all the way up to the lower esophagus, possibly bleed into the stomach, and the patient bleeds out, basically. What's going on here? I have a little hint down here. What's going on? Talked about this a number of times. What is this? What is this right here? We got got this vessel right here. That's a portal vein, right? Which one? Left portal vein. In fact, this isn't just the left portal vein, it is the umbilical segment of the left portal vein, okay? What does that make? What's that make this white line? This echogenic line. It's really different on different people. Ligamentum teres, okay? This is normal. Ligamentum teres is normal here. Here we have the umbilical segment of left portal vein is right here. We're going to call this a patent ligamentum teres, or a Another term for it is also recanalized, recanalized umbilical vein. So in this person, I guarantee you there's only one direction for this blood to be flowing, and that is out here all the way down to the belly button. This is basically the liver doing what it can to decompress itself of all the pressure. And actually, when this happens, it's bad. I mean, obviously this person's very sick. They have really bad cirrhosis. It's not a good thing overall, but it's better than the alternative. And so what it's doing, it's decompressing the liver. It's decompressing, actually, I should say, the portal system. So now that very high pressure in the portal system is going to be relieved by this. And that's a good thing, because now these varices aren't going to grow bigger. They're not going to bleed. And in fact, a lot of times doctors do something like this on purpose. In retrospect, I should have grabbed that image, or a couple of images. But they do a TIPS procedure, transesophageal intrahepatic portal systemic shunt. What does that mean? Well, you know what? Let's use a picture right up here for that. We'll use this picture. You know what? Actually, we'll use my drawing. Even better. TIPS procedure. Oh, did I just say it wrong? I think I said it wrong, guys. TIPS. Oops, that idiot. I hope I said this correctly. If I didn't, this is the correct way. Transjugular intrahepatic portal systemic shunt. I might have said it backward, or I might have said it wrong. All right. In that case, so what they're doing is they're going through the jugular. Let's go ahead and do this. Damn it. Let's take a shunt. I need a new color here. Oh, we'll make this a green shunt. We're going to come through the jugular vein and come down the SVT, the superior vena. I'm sorry, SVC, the superior vena cava, through the atrium into the IVC. They're going to choose whichever one makes sense. They're going to choose, let's say the middle hepatic. Middle hepatic is actually very close to the left portal. Oops. Okay, I went a little too far. It's actually, so what ends out happening is that it creates a shunt between the portal vein. This is the cage of the shunt. Between the portal vein and the hepatic vein. So what that does is decompresses the portal hypertension and allows most of the portal blood to bypass the liver and go into the IVC and back to the heart. Obviously not human design. We don't want to do that. We want to do that in utero, but we don't want to do that as a living, breathing adult or child. But it's better than the alternative, and it works for a number of years. It extends the life for a number of years. Okay, 10, 11, I gotta, oh no, it's Friday. I don't have to. I love seeing you guys. Let me stop share here. I love seeing you guys Monday, Tuesday, Wednesday, Thursday. But Fridays are a little special in my heart because I don't have to go in. That's good. Actually, maybe I'll put out another video because it's only 10, 11 in the morning. I have some other things for school I do have to do, catch up on some things that are overdue, but create some homework. You guys have to start producing homework assignments for you guys again, because since we're not visiting in person, I have to do that instead. Okay, I'm just rambling. So rather than continue to ramble on, this one is done. End it.